Jeffers. I am an assistant professor in pediatric emergency medicine at Johns Hopkins University. I am also the co-chair of the education committee within IPSS, and we are sponsoring today's webinar with Anna-Theresa Lobos, who I will introduce shortly. But just to get started, for those of you that are not IPSS members, please consider joining so that we can continue to promote and support multidisciplinary simulation-based education, training, and research across all subspecialties that care for infants and children, and be able to offer more programs like this in the future. Please check out IPSS's website at ipssglobal.org to see the benefits of membership. And a few quick housekeeping notes before we get to the presentation today. Please feel free to ask questions during the session. I would encourage you to do this by, if you look at your panel, there's a tab for questions. If you open the tab, you can type in your question, and we will try to get to them real-time response, but we will have about 10 minutes at the end of the session to answer those questions. So today is the first in a series of webinars that are celebrating the award winners from IPSSW 2018 in Amsterdam. And I have the pleasure of introducing Dr. Anna-Theresa Lobos from the Children's Hospital of Eastern Ontario, or CHEO. She will be discussing getting to the root of the problem, using simulation to analyze adverse events, improves error discovery, and generates better strategies for error prevention. Dr. Lobos is an associate professor at the University of Ottawa, Department of Pediatrics and Division of Critical Care. In addition to her role as a pediatric intensivist at the Children's Hospital of Eastern Ontario, she is the Pediatric Critical Care Program Director, the Medical Director of CHEO's Medical Emergency Team, and the Medical Director of Simulation at CHEO. Her interest in interprofessional education and the recognition of acute illness has led her to present at national and international conferences and published numerous papers on the Ontario Medical Emergency Team experience. Dr. Lobos is also the co-chair of CHEO's Early Response and Resuscitation Committee, which works to create hospital-wide policies and education programs focused on the recognition and management of the acutely ill child. Dr. Lobos' research in simulation focuses on using simulation to improve root cause analysis after adverse events and developing simulation-based courses to improve the care of acutely ill children on the pediatric ward. So with that, I will turn this over to Dr. Lobos, and I look forward to her presentation.
Thank you very much for that introduction. It's very exciting to be speaking to everyone all over the place from Ottawa, which I will let you know we still have about 4 feet of snow. So if you don't, consider yourself lucky because we are still fairly snowed in here. So as Justin mentioned, I'm going to be talking about using simulation to improve error discovery. And I just wanted to acknowledge my co-investigators that are on the first slide here. I have no potential conflicts of interest to report. So just as a background, I think many of us know that adverse events during hospitalization are unfortunately very common. When I say adverse event, I mean something that is a negative consequence of healthcare that results in an unintended injury or illness that may result in something as significant as death, disability, prolonged hospitalization, or readmission. And so we know that given that kids are different, especially with weight-based medication dosing or differences in patient-provider communication, they're at very high risk of adverse events. And some studies suggest that up to 13% of hospitalized children actually experience an adverse event, with almost, or I should say more than 60% determined to be preventable. So we know that healthcare teams often use, or almost most commonly use, root cause analysis to understand why and how these adverse events happen, and then to prevent reoccurrence. So for those of you who might not be familiar with a root cause analysis, this is just a very simple diagram that can go through how teams use root cause analysis to find the issues with respect to the problems that they're trying to solve. So using a very systematic approach, it's usually a team of expert clinicians and quality improvement leaders that are not often involved in the adverse event, that work together to retrospectively understand what happened, why it might have happened, and then how to prevent reoccurrence. Usually they review clinical documentation, they interview different individuals who may have been involved, and then the RCA team creates a flow map which is sort of like this, a bit of a simple picture that allows the team to see what happened in the order it occurred. So they might, obviously this is a blank diagram, but they'll fill in the blanks as to what the problem they think happened or what happened to cause the problem. And then they identify these causes of errors and then categorize them into system versus individual contributing factors, which then lead to recommendations for prevention. Unfortunately, if you're to examine the patient safety literature, we have found and we know in real life that there's significant limitations of the RCA process. So different authors have suggested that most RCAs are actually performed incorrectly and often inappropriately place too much emphasis on the discovery of a single key error. Another really important limitation is hindsight bias. And so that is sort of like when you know the results, you know the outcome of the problem, that you sit back and think, why didn't I see that? Or why didn't I see that? It's sort of that common, you go to an M&M rounds and someone presents a terrible case and you're sitting there in the audience thinking, oh, I can't believe they didn't see that. That's hindsight bias because you already know the outcome of the case. Instead of identifying significant system-based aspects of the event, sometimes the RCA process reveals that people just make mistakes, like they forget something they've previously known. And in addition, many studies have shown that many adverse events reoccur repeatedly, even after implementation of the recommendations, implying that the quality of the recommended interventions were poor. Interestingly, the most common recommendations after an RCA are re-education and policy creation, which I'm sure you're all familiar with at your hospitals. And these interventions only have a very small chance of reducing recurrence. So given all of this, we think, and we've seen in previous studies, that simulation may have a very important role in improving the RCA process. Simulation studies in pre-hospital care and surgical patients found that using simulation and debriefing and event analysis helped identify multiple underlying causes of teamwork errors and latent risk factors. So those are latent risk factors are things that make errors more likely, and more specifically system errors, especially in the surgical cases than a traditional RCA. To our knowledge, this is the first report to use simulation-based event analysis in hospitalized pediatric patients. So the objective of this first part of our study was to investigate the ways in which simulation-based event analysis is different from traditional event analysis in uncovering these root causes, latent risk factors, and generating recommendations when analyzing adverse events in hospitalized children. So as Justin mentioned, I'm from CHEO, which is a pediatric hospital in Ottawa. We're a tertiary care pediatric hospital with over 6,000 admissions per year and 170 inpatient beds. We, of course, obtained ethics approval from our Mauritius Ethics Board. So how do we figure out what the cases were that we would try to simulate? What we did was we looked at safety reports that were in our CHEO safety reporting system over a course of about 3 years. The reports that go into the safety reporting system include things like near misses or actual adverse events, privacy breaches, or hazards in the workplace. And we considered cases if the event occurred in the clinical area, included more than 2 clinicians, already underwent analysis by the hospital's care review committee, and we thought it was amenable to simulation. We prospectively chose not to include surgical and mental health events just because of the challenges in accurately simulating those surgical complications. We don't have that type of simulation equipment available to us. And then, of course, very unique mental health scenarios that we didn't think we could replicate in simulation. In the end, we chose 2 events. The first event we chose, we'll call event A, and I'll describe it in a bit more detail in a second, but it was an error of commission, which means a mistake that consists of doing something wrong. And why we chose this particular one is because we were curious if the error could be replicated. Event 2 was detecting an error that already occurred, and our question in this scenario was how quickly could clinicians recognize an error and limit patient morbidity. We decided to choose event A because it is something that happens in the literature all the time. And I show you the next slide, you'll probably say, yeah, I've heard of this mistake happening a fair bit. So event A involved a hospitalized inpatient with known allergies who experienced anaphylaxis on the pediatric ward. They received the correct medication, it was epinephrine, but the wrong dose and the wrong route. They experienced this anaphylaxis and were given 1 in 1,000 epinephrine. They actually got 10 times the dose and were given it IV. As mentioned, I chose this event, or our group chose this event, because of the repeated reports in the literature of people choosing IV epinephrine for anaphylaxis instead of IM, and knowing that when we give IV epinephrine for anaphylaxis, we are at a very high risk of severe cardiovascular complications. Event B was a critical care patient with traumatic brain injury who was admitted to the intensive care unit, and this patient had diabetes insipidus. they received the wrong concentration and wrong dose of vasopressin. So they received the dose that we would usually give for shock instead of for DI. And this was also complicated by communication concerns during patient handover. We decided to use this event because it involved a different in-hospital environment, being the ICU, and included a communication concern during handover, which certainly has been recognized internationally by a variety of groups as a significant cause of adverse events. The way that we developed the scenario is by reviewing all the charts. This was reviewed by our simulation and clinician experts, and they extracted key characteristics which we used to create scenarios that mimic the real event. We only really changed sort of minor identifying characteristics like age and gender and a little bit of details in the history, but that was only changed for privacy concerns. We also developed medical records like admission documentation, order sheets, medication records, etc., to enhance realism. And all the scenarios were using the Laerdal high-fidelity mannequins. With respect to the participants, so we recruited participants with similar training and skill set to the clinicians involved in the real-life events, so nurses and pediatric trainees, and they were recruited from within our institution using a variety of means, so posters, meetings, newsletters. We certainly did not track individual performance, and all the data points were later de-identified. Just of interest, we did give the participants a gift card in appreciation of their time, and most of the simulation sessions for the physicians and actually some of the nurses were eligible for continuing education credits. So what we did next was we knew that we had to do it in situ, and I'll explain why we did that in a little bit, and we also video recorded the scenarios as well. Participants before the scenario started were told that they had access to the interventions from the real-life event reviews. So when these events already happened, the RCs had already been done, and the interventions were already in place at CHIO, and they had access to them, including pre-printed order sets and online references. Participants also received a standardized pre-briefing prior to participating in the scenario and signed a consent. So the standardized pre-briefing included us telling participants a couple key things. We said to them, you will be asked to contribute by participating in a simulation scenario and debriefing based on a real-life adverse event that occurred within the hospital. We told them that the purpose of the study was to study adverse events and to see if simulation and debriefing discovers different or more causes of errors. We told them that obviously the scenarios would take place in situ and that there would be up to 45 minutes of debriefing after. We also told them that it is possible that they could be uncomfortable participating in the scenario in which a patient error may occur, albeit simulated. But we also told them that this discomfort was not expected to be any more likely than would occur in any other simulation training opportunity. Based on our previous research and previous studies, we found that the study protocol had suggested a priority that scenarios were repeated up to 6 times, and this is because previous studies I'd mentioned in our background also repeated them up to 6 times or until data saturation was achieved. I will say this later, but just so you know now, 5 simulations were completed for both scenarios, and in both cases, data saturation was actually achieved after 4 cases. Now, for scenario A, we had 2 participants. In scenario B, we had 3 to 4 participants, and each scenario involved a Confederate. In scenario A, the mannequin's vital signs were preset to mimic anaphylaxis, and clinicians were shown a picture of a typical urticarial rash. The scenario ended when the epinephrine was given, regardless of dose or route chosen, with an average duration of the scenario being but 11 minutes. For scenario B, the mannequin's vital signs were preset to demonstrate evidence of a vasopressin overdose. And this particular scenario ended when the error was discovered, so the wrong concentration and rate of vasopressin infusion, and the clinicians initiated the appropriate dose and rate with an average runtime of about 23 minutes. Following each simulation, a 45-minute debriefing was held by trained facilitators and was just transcribed by our study coordinators. We also video record these, mostly just to ensure accuracy of the transcripts. Really important that the debriefing occurred in the clinical environment. So we stopped the scenario and just sat down in the chairs that were provided in the space. This was to allow participants to really reflect on their surroundings. During the debriefing, we explored the participants' decision-making processes and, of course, used things like advocacy inquiry and standard open-ended questions to explore their performance. Really important as well to sort of limit that hindsight bias we talked about before. Only in the middle of the debriefing, sort of after most of the discussion had happened about their initial sort of performance and treatment decisions, participants were then informed about the outcome of the actual case. so therefore allowing for more reflection then about why they did or did not make the same errors. The final part of the debriefing focused on the development of recommendations for error prevention. We asked them questions like, how would you make it safer for colleagues to do the right thing? What would you do if you were in charge? How would you change the system? What would you do differently, etc. We also provided participants with an anonymous participant survey, and this really kind of looked at their comfort, how the debriefing went, how they thought the scenario was, and I'll show you the results of that in a little bit. Another little component of our study that we wanted to do, which is sort of like a side question, is could experts observing a simulation alone add to the event analysis process compared to simulation with immediate participant debriefing? And so what we did is when we recorded all the simulations, we had them reviewed by 4 previously selected expert reviewers, and these included a pharmacist, a physician expert in patient safety, a patient safety hospital administrator, and a physician expert in simulation and medical education. All of the reviewers are engaged in the RCA process at their institution and have advanced patient safety training. We really did this to see if experts observing a simulation alone, so just basically watching people run through these scenarios and making mistakes or not making mistakes, could add to the event analysis compared to simulation with the participants and debriefing after. All the reviewers received an encrypted USB key, and they were independently reviewed, and data was collected using a predetermined study template that we provided to them. So with respect to data analysis, so after data saturation was achieved, analysis was carried out in multiple stages. So to reduce bias, we had multiple team members analyze the data separately. We had a qualitative methodologist who was wonderful, and she really helped us understand content analysis using deductive and inductive approaches to coding. And we used that to analyze scenario and debriefing data. The data was collected through the debriefing process, which included notes from the investigators attending the debriefing and also the transcription. And once the debriefing was transcribed, the debriefings were de-identified with participants coded only to their discipline to facilitate analysis. Transcription was undertaken by a member of the study team, and we did not use any software for quoting. So the team used comparative matrices to organize the themes and undertake cross-case analyses to determine similarities and differences across the cases. So given that the data was produced at different time intervals, it was analyzed in a parallel convergence model, which basically means that simultaneously both the qualitative and quantitative data was collected and eventually merged to form the results. What we did at the end was look at the final study recommendations, and we compiled a list of root causes and recommendations from the simulation-based event analysis, and then compared them to the real-life traditional event analysis that was provided by the hospital's Quality of Care Committee. All right, the results. So as mentioned, we did 5 simulations for both scenarios, and data saturation was achieved after 4. So in scenario A, this is our epinephrine scenario, in 60% of the scenarios, and remember that participants in these scenarios had access to all of the recommendations from the traditional event review. So the pre-printed order sets, online references, education sessions, everything that was implemented after the real-life adverse event, these participants had access to. So 60% of the scenarios, the adverse event was reproduced and it was similar to the original event, to the horror of our patient safety experts here at CHIO. So in scenario A, I'm just going to remind you sort of what happened in the real life event. In the original case, patient was admitted to the inpatient pediatric ward following an anaphylactic event at home. The patient then experienced another episode of anaphylaxis, but they were normotensive after exposure to food. The patient was given the correct medication, as I mentioned, epinephrine, but the wrong dose via the wrong route. And unfortunately, in this particular situation, the patient was transferred to the intensive care unit for monitoring because of cardiovascular complications, but luckily had no long-term morbidity. So simulations conducted in the clinical environment, and all clinicians were provided a similar history. So with respect to the epinephrine scenario, all participants knew that the patient had anaphylaxis and needed immediate management with epinephrine. However, as mentioned, 60% gave the wrong dose or the wrong route. It seemed like what happened for these physicians and nurses was there was a significant confusion about the appropriate route and concentration of epinephrine. And what we really found was that people just didn't know what to do when a patient had an IV. So here is a busy slide, but it just provides some examples and some themes around the causes for error. So there was clearly confusion about route, memory aids that people were using, the PALS card, which is given by the American Heart Association. There's confusion about these in-house sort of hospital resuscitation teats that we have at CHEO that are at the end of every bedside, and confusion about medication labeling. So examples are, confusion about route, really common. People saying, I focus on the IV because it's quick access. I didn't want to poke the kid. We already had an IV. People talked about looking at the vial of the 1 in 1,000 and saying that they just were confused. And it says you can give it IV, but what people didn't realize is that's when you dilute it and put it in an infusion if you're in the ICU. But just a lot of confusion about memory aids as well. So for instance, the hospital resuscitation teats, people said stuff like, oh my gosh, there's too much text. Things were organized improperly for them. They didn't see the indication. It was very confusing for them. Now, interestingly, clinicians who didn't make the error revealed that they relied on personal experience to make the right decision. For instance, they've had experience treating anaphylaxis correctly, or they actually heard about a patient receiving IV epinephrine and experiencing side effects, and so they didn't want to make the same mistake. Interestingly, none of the participants who did not make a mistake used the real-life intervention that was implemented after the real-life adverse event. Now, during the traditional event analysis, the error had been attributed to lack of knowledge regarding anaphylaxis treatment, lack of knowledge regarding the use of the hospital gestation medication sheets, and lack of nursing knowledge regarding where to record allergy status in patient charts. And so, not surprisingly, what came out of the original real-life adverse event is a pre-printed order policy development, which, as we know in the literature, is very common, the number one thing that's recommended after RCAs, but doesn't seem to be effective. In addition, from the real-life adverse event, the pharmacy also agreed to review the number of vials of epinephrine ward stock, and if it could be safely reduced. They never removed the 1 in 1,000 in little vials. They just decided they would review it. With regard to our simulation-based event analysis, though, people recommended different things. So they recommended for medication labeling a creation of a specialized drug kit. So you might be sitting there at your hospital thinking, I don't understand why they don't have EpiPens in their hospital. Why does everyone have EpiPen? Well, we don't, because they're really expensive, and so we've never actually had them available to us. So what people recommended here was the creation of a specialized drug kit. So small bag containing everything you need to give the right dose, the right route, and the right concentration. So a small bag containing an IM needle, IM epinephrine with a label reading, do not give IV. In addition, people were confused between the box dose of epinephrine, which is the 1 in 10,000 for arrest. They wanted to put do not give IV on the box and make sure that very specifically on the vials it says IM only. The other thing that people recommended was guarding against harm. So something like an alert sign with very clear messaging in patient rooms, such as I have anaphylaxis. If I have these signs, give me IM epinephrine only. Do not give me IV. Participants also recommended removing completely just random vials, little glass vials of the epinephrine as ward stock, and only having them available in the anaphylaxis kits. This is an example of the epinephrine kit that was made up following the simulation scenarios, and as you can see, it's sort of what the participants recommended. In addition, again, not surprisingly, the number one thing that's recommended after RCAs is education. And so in traditional event analysis, it was recommended that nursing educators and physician educators review medication resuscitation sheets, they educate staff on how to use them, and they investigate options to re-educate nursing units with regards to recording allergies and diet orders. From the simulation-based analysis, though, people focused on actually making the resuscitation sheets easier to use and easier to understand, like listing medications alphabetically, or bolding the IM epinephrine dose, or listing the indications for the medication first. In addition, of course, not surprisingly, people did, of course, recommend education as an option, including sessions of common 5 mistakes or standardized common emergency management cards. So moving on to scenario B, and again, I'll remind you this was about vasopressin. So in the original case, a neurologically stable intubated patient that was in the PICU for 7 days following TBI was placed on vasopressin for DI, and the dose and concentration were administered incorrectly, and the patient in real life experienced significant nuance of hypertension, which was shared with another healthcare provider on the PICU team. This error was not discovered until after the patient was en route to a CT scanner, about 20 minutes later, to assess for raised intracranial pressure. So the simulated study scenarios were conducted in the ICU, and the participants were provided a very similar history. We began the scenario with the incorrect dose and rate of the vasopressin already infusing, and our goal was to assess the rate of error discovery. our Confederate nurse provided a brief handoff to the voluntary participant, and the scenario began. So the participant, we said, could ask the nurse as many clarifying questions to the Confederate nurse as they would do in real life during a handover. As the scenario progressed, the participant nurse discovered the patient had new onset hypertension and often called the physician, actually every time called the physician. All healthcare providers eventually discovered the drug error and took about 15 minutes to do so. So a little bit better than real life. No one was wheeling the mannequin to CT, but it still took about 15 minutes to discover the error. Initially, most providers attributed the hypertension to traumatic brain injury and spent a lot of time assessing the patient's neurological status. And the simulation was conducted in real time and ended the moment the correct concentration and rate of vasopressin was initiated on the pump. So on average, it took about 8 to 10 minutes between stopping the incorrect dose and concentration of the vasopressin and ordering and initiating the correct dose of the vasopressin. So what we found during our debriefing was that participants revealed multiple reasons why the initial error could have occurred, and the challenges of sort of systematically analyzing an acute patient change and what led some teams to look for a medication error earlier than others, as well as a lot of challenges with handoffs. So these reasons included, number one, again, significant confusion around drug dose concentrations for vasopressin. Number two, labeling of infusion medications. And three, a real feeling about a lack of standard work with regard to handoff. So when a nurse goes to break, what does she tell her relieving nurse when she goes? She says, this is so-and-so, he's been stable, I'm going for break, or what information is really important to pass on during break? So again, here's some quotes from this particular scenario. So a lot of confusion about drug dose. So most nurses and physicians said, listen, I don't remember which concentration and doses for which diagnosis, shock or DI. It was 1 per minute, 1 per hour. It's very confusing to me. Confusion about medication labeling. So a lot of physicians just said, listen, I trust the pumps. I trust that the nurses know what they're doing. I don't even look at the syringe. I'm not trained to use the pumps. The nurses felt the labeling from the pharmacy was difficult to find on the syringe. And again, nurses made these comments about break coverage. So when I'm covering for break, I assume the bedside RN had done this all and everything's correct. Other nurses said, we don't often check pumps when we leave for break. You think about doing it, but you don't. Physicians again say, I assume the pumps are okay. So the recommendations from the traditional event analysis for scenario B were almost all around education. So clarifying the DI guideline that we already had in place in the PICU, updating a protocol binder and creating an online reference site, and then clarifying the dose and preparation for vasopressin. In contrast, the simulation-based event analysis, participants recommended all different sorts of things, like a better product labeling. So maybe matching colors between the syringe and the pump for each concentrations of doses, i.e. yellow for vasopressin for DI, red for vasopressin for shock. They also wanted to guard against harm using alert signs on the infusion pumps. So things that say high alert medication, vasopressin for DI, units per kilo per hour, or vasopressin for shock, units per kilo per minute. In addition, a lot of great conversation about how we transfer knowledge on handoff. And so we certainly know about the great work about checklists, but people recommended creating a checklist for break coverage. So just a brief standard checklist for a change of care provider. So just moving on to the video analysis. So we actually found that when we looked at errors and recommendations generated from the scenarios and the debriefing with participants, we actually did not receive any additional data or different ideas from the experts who just watched the videos alone. The participant survey revealed that people had a great time doing simulation, not surprising. Of course, I think we see this with a lot of simulation studies, that everyone thought that there was excellent debriefing and they had a lot of satisfaction with debriefing, and 93% of participants thought the quality of the scenario was excellent as well. So overall, this, as mentioned, is the first study to use simulation to analyze adverse events in hospitalized pediatric patients. And we found that compared to traditional event analysis, simulation-based event analysis identified unique causes for errors and new recommendations for improvement. We think that we obtained a better real-time understanding of why errors occurred through the immediate discussion of ideas and concerns by clinicians providing the care in their usual environment. So, root causes are different. So we found that many of the root causes identified by our simulation-based event analysis were different than the causes identified by the traditional event analysis. So for example, for the EPI scenario in scenario A, the traditional RCA pointed to lack of individual knowledge as a significant cause of error. So lack of education, lack of experience with the hospital resuscitation sheets, which of course led to implementation of a PPO, or a pre-printed order set for anaphylaxis. In our simulation, though this changed, so the PPO was already in practice, no one decided to use it. And when we asked them why, they said they forgot to use the PPO and relied on memory instead, even with a known anaphylaxis patient in front of them. So we know from previous studies that the problem with focusing on individual error and trying to fix it with a policy change usually only deals with just part of the problem. Obviously, our studies showed that re-education and policy writing were actually ineffective at reducing risk and were indeed weak actions, as suggested by many previous experts. So again, compared to the recommendations generated by the traditional event analysis for both simulations, ours found that we probably had better and more unique strategies for error prevention. So we know that the patient safety literature suggests that the most effective interventions or strong actions conceived through an RCA process consist of designing changes to remove the hazard and physically guarding against the hazard. So our study also found the same, that the recommended improvements from the participants in the scenarios dealt with this specifically. So number one, design changes. So new anaphylaxis kits with clear labeling and IM needles already in place. New infusion drug labeling. So color coding between syringe and pump. Or two, physically guarding against the hazard by just removing the 1 milligram per mil epinephrine vials as ward stock. And then three, alerting staff regarding hazards for both scenarios by placing alert signs in the patient rooms for patients with known anaphylaxis and using alert signs on infusion pumps for high alert medications. So overall, we felt that the interventions suggested by our simulation-based event analysis addressed system changes, not individual changes. Redesigning a product, as suggested in our analysis, has a very high probability of reducing harm. Again, busy slide, but I think this really highlights why we think simulation-based event analysis is better and what the advantages are. So we know that previous studies suggest that traditional event analysis, or RCAs, place too much effort on this discovery of a single key error or on individual performance. The difference with simulation-based event analysis is that you're looking at numerous different individuals who are all making the same error, which really suggests that individual mistakes and errors in judgment must be corrected by a broader system issue, such as labeling of medications or readability of resuscitation sheets. Simulation-based event analysis is also different because, as you guys know, with RCAs, people are usually sitting months later, weeks later, in a back room, big conference room, clinicians plus some hospital administrators who weren't involved in the A talking about the event. Why simulation-based event analysis is different is it's conducted right away in the clinical environment with a debriefing immediately in the clinical environment. It really allows the individuals to reflect on the environment. They can actually feel and touch the medications they use, look at the labeling, look at the equipment. It really allows them to reflect better. And hopefully it doesn't allow us to be focused only on one specific error or just someone making a mistake. The other neat thing about simulation-based event analysis is people didn't make the mistake, and we still debrief with them as well. And so remembering that traditional event analysis, people that are interviewed through the process are the ones that were involved in the mistake. So debriefing with individuals that didn't make the mistake also provides really interesting results and provides us with a better understanding of why healthcare providers make the right decisions. As mentioned before, traditional event analysis is fraught with problems with hindsight bias. So hindsight bias, as a reminder, occurs when a clinician or an investigator knows the outcome of the event and then believes the steps needed to prevent the outcome are obvious. So that classic, like, why didn't they see it? Why didn't I see it, etc. So simulation-based event analysis improves this hindsight bias and provides a better understanding, given that we don't reveal the error right away when we're talking to people. As I mentioned before, during the epi scenario, participants were asked about their decision. So tell me about how you gave the epinephrine. Why did you give it IV? Why did you choose this dose? Before the error or the outcome of the original adverse event was revealed. And this really helped participants and investigators to really to understand the thinking and improve this hindsight bias. Finally, I think one thing that the literature talks about a lot with RCAs is sort of that interrogation feel. So you're interviewed by hospital administrators, patient safety experts, maybe senior clinicians about why you or didn't you make a mistake. Whereas simulation-based event analysis is really that blame-free environment, and participants really felt open and comfortable to express their ideas and concerns. they really felt motivated to fix the problem as well, to the point that actually one of their residents who made a mistake in the epi scenario felt so passionate about her PALS AHA card that she decided she was going to call PALS AHA to make it more clear on their card that they could make the dose of epinephrine and the route for anaphylaxis a bit more clear for her and for everybody else. So a couple of lessons learned. First of all, obviously this takes a lot of time, and what we would suggest is that you're choosing high impact adverse events to simulate. Certainly those are ones that cause moderate harm or are a serious safety event in your hospital. So overall, the selection of cases, the creation of scenarios, and recruitment of participants probably took an average of about 12 person-hours. And then the facilitation scenarios themselves and debriefing took an average of about 2.5 person-hours per scenario run-through. The other thing that we learned is that the in-situ environment is essential, and of course that was the whole premise of our study, but it cannot be overstated that it must be done in the clinical environment to really gain insight into how the environment might impact the chances of errors. So certainly this is not something you want to do just in your sim lab, because you really want to get clinicians in their home environment to really use the things around them. Debriefing. So debriefing is obviously essential. That pre-brief that I mentioned was essential to get people familiar with the study and why they're there. But also the debrief is essential. Of course, skilled providers, we know debriefers create a very safe environment for learning and open dialogue by really establishing trust, clarifying objectives up front, and really allowing individuals time to process reaction and feelings. And I would say that this is probably essential if your hospital is going to partake in this, is you really engage simulation experts to be involved in the debriefing, because that part is really essential, that advocacy inquiry model. Scenario selection, so certainly the scenario A, where clinicians have to decide to do a treatment, much easier to replicate than that sort of error already happened and now we're discovering it. And then the final piece I would say is the follow-up. So it's interesting that even though we did a lot of pre-briefing and debriefing, we still had to follow up with some participants to ensure safety. And what I mean by that is lots of people, when they made mistakes, felt pretty sad and regretful. And so just making sure that we followed up with those clinicians afterwards is really important. So of course, limitations with the study. So this is a single center study design, and we certainly think that our own hospital, I would say, over the years has gotten much better at root cause analysis. And my patient safety leadership team here would tell me they've done a lot better, and they're not just suggesting policy changes and education when they have adverse events. So maybe, if we did the study now, things would be a bit different. Of course, there's a significant investment of time, people, and resources, and that we still might not entirely reproduce the original experience or environment completely. And of course, participant anxiety is always a limitation in simulation studies. So in conclusion, we think that simulation-based event analysis increases the discovery of unique and different causes for error and new recommendations compared to the traditional approach. We think it's different because of the immediate debriefings with the different clinicians providing care in their usual environment. We had debriefings with those that didn't make the error, and we really have an organic discussion following an adverse event, which really limits hindsight bias. We believe that hospitals should consider simulation-based event analysis as an important addition to the traditional process. And just as a little plug, stay tuned. Part 2 of our study, we have used simulation to test and optimize the interventions that were recommended during this study prior to widespread implementation. So with that, that is the end of my formal part of the webinar.
Well, great. Well, thank you so much. That was a wonderful talk. I'm thrilled that you were able to share it with us. You actually answered a handful of the questions I wrote down, but I want to remind people on the line that you can use the question tab in your webinar rectangle to type in questions if you have any, and I'm sure Dr. Lobos will be happy to answer them. One question I do have is that, and you mentioned kind of the limitation of using simulation is time and resources, but we also know that traditional RCAs are fairly time and resource intense as well. And do you see sim as being sort of a complement to traditional RCAs, or do you think there's an avenue or a place for sim to replace traditional RCAs, or some sort of combination?
Yeah, that's a really good question. So in talking with our patient safety experts here, I think, it's just so ingrained in hospital policy that they do traditional RCA. At the same time, though, since we did this study, we have used simulation in real life adverse event recreation again. And I would say that the patient safety team is seeing the value and probably will limit the amount of time they spend on a traditional RCA to include time for simulation, because it certainly seems like we're getting a lot more richness of data from simulation-based RCA. So do I see it replacing it? Not entirely. I think there's always that, sort of corporate administrative responsibility to do their investigation initially, but do I see simulation complementing it? Absolutely.
It looks like we do have a couple of questions popping up, and the first one, any recommendation for a specific debriefing tool?
Oh, that's a really good question. So, you know what, I have to plug, Adam Chang and the group, Vince Grant and the group at Harvard as well. I think just using the advocacy inquiry method is extremely important, and I would suggest that is, a way that I would go in this situation for sure. I would use your standard simulation debriefing. I think what was great about this is none of my colleagues who were involved in the study, two of the investigators are patient safety people, but the people that were doing the debriefing are all simulation educators. And, that's the training they've had. It's not about patient safety or RCAs, it's all about simulation. And so just with their sort of, WISE training, Harvard training, advocacy inquiry training, they were able to do a wonderful job with the debriefing. So no, I would use standard sim debriefing because that's what seems to set the stage for that sort of safe space.
Next question, can you discuss how you plan to use simulation to test the interventions? Will you use the same cases, different but related ones?
Yeah, no, great question. So we've finished this and we're hoping that we can talk about it at the next IPSSW, but what we did was we looked at the same cases. We took the interventions that were recommended by the simulation-based event analysis, so the epi kits, the signs, removing epinephrine, labeling the 1 in 10,000. For the vasopressin, we developed a checklist for break handoff, and we ran the same simulations. And I'll tell you that we ran 8. So just as a little, I'm not going to tell you all the results, but we ran 8 scenarios for each event, so total of 16 scenarios. And what was fascinating was that we had to edit and modify the interventions through simulation. And so that was the best part, is that here they were generated. We thought they were great as it was. And what this shows us is that you just need to continue to test them. Now, a lot of them worked, on the first go. But you know what? Some of them didn't. And, for instance, one of the signs, we had this really kind of elaborate anaphylaxis sign with pictures and all that really kind of cool stuff. That one didn't work at all. The best sign that worked after modification was literally a sign that looked like a stop sign that said, "Stop, I have anaphylaxis." In big, bold letters, give me, I am epinephrine. This is my dose. Do not give me IV. And that seemed to work. So certainly we would advocate that simulation is also essential. Then if you think you've got this great intervention, that you test it in lots of places, because, again, it's those kinds of things need modification. So, yeah, we use the same scenarios, obviously different clinicians, and the interventions that were generated through this particular study.
Next question, what was the breakdown in epi error in terms of route versus dose?
And yeah, that's a really good question. So the breakdown in error, so of the people that made the mistake, all of them made the mistake of the route. So the mistake, when it was made, everyone got IV. And then with respect to the dose, so unfortunately, one of them got 1 in 1,000 IV, and then the other ones got 1 in 10,000 IV.
And also, did you ever have the actual participants perform in the simulation?
So the people that really made the real life adverse event, is that the question?
That's how I interpret it, yeah.
Nope, we did not do that. Mm-mm. And I don't know, yeah, it's an interesting thought. No, we did not have the real people participate.
Did you guys talk about it? Was that a conscious decision?
Yeah, you know what? It's funny. We didn't actually talk about it. I don't think it was conscious. Since, as I mentioned, since our hospital has sort of embraced this as an option for looking at adverse events, there was a issue with a PCA pump on the inpatient ward, and they did actually use the same people who made the mistake more to guide the development of the scenario than the actual being participants. So no, I think it'd be very interesting to engage the people that actually made the mistake and see sort of what they would do now and how they would design a scenario.
Next question. I hope I interpret it right, but how did you share the learning from your sim-based RCA, whereas more traditional RCA meetings where larger groups can engage?
That is a really good question. So luckily, one of my roles is as the co-chair of our early response resuscitation committee. And so what that committee does is we review all the code blues in the hospital and all of our MET team activations. But the other thing that we do is we seem to, I don't know how I got this power, we seem to have a fair bit of power with regards to, resuscitation medications and all that kind of stuff. So I had gone to the patient safety team, the quality of care committee, with the study results and said, this is what we found. What do you guys think? And they told me to run with it. So what we've been able to do is implement a lot of these changes at CHIO, just because of the willingness of the patient safety committee and our committee to be able to push this through. In addition, we've done a lot more simulations on the inpatient ward, using some of the interventions to make sure that they're suitable for the inpatient ward. So yeah, we've definitely gone back with our findings to the quality of care committee and made sure that our findings will get into the system, because I will tell you that the events now, before we've implemented, the events of epinephrine, given the wrong route, were still happening. So we definitely wanted to implement these.
That's interesting. And then the same person who asked about debriefing method has a follow-up question. Is there a standard sim debriefing? I've attended 2 different sim courses with 2 different sim styles taught. I guess we will choose what fits our style best.
I think that, the very first thing, of course, we would do is to make sure there's a reaction phase. So, everyone sat down, we sort of said, how do you think that went? How did that feel? And then, once everyone kind of decompressed, then we started asking some questions. So, tell us about the case. Tell us about your diagnosis. Tell us about, I noticed that you use like a lot of accuracy. I noticed that you used epinephrine, and I noticed that you chose this particular dose in this particular route, and tell me more about that, and tell me why you made those decisions. And so a lot of sort of exploration, and then kind of midway through the debriefing, we said, okay, so thank you very much for that information. I need to share with you the results of the original adverse event, and this patient got epinephrine. And most of them, when you told them that, they realized they made the mistake, and they went, and then there was a lot more time for conversation. And then the conversation flowed about, do you have any more reflection now that, you've realized that was an error? Do you have any more thoughts? And then the conversation shifted to really advocacy about how to make this problem go away. Because I think the other important point is once people realize they made a mistake, they feel terrible, right? It's a fake mannequin, like the whole thing, but they feel terrible. And so switching that feeling of guilt and shame or whatever else they're feeling to positivity at that point is essential. So then we would switch gears and say, you know what, guys? Normalizing it, like, man, we read about all these mistakes in the literature, and this happens all over the place, and this happened last week too, and so we really need your help to make the hospital safer. And so as we switched gears at the end of the debrief, it was all about how can we make the hospital safer? How can you help me? And then they got really motivated, and then it was like, let's do this, let's change this, let's move, and that felt good, and I think that's what ended the debriefing on a positive note. So that's how I would say I would structure the debrief, if that helps at all.
Yeah. So did they kind of turn into more like a brainstorming?
Yeah, it really did. Like by the, after sort of the reveal of the error, and then that sort of reactions phase about that, and a bit more sort of advocacy inquiry about their feelings, then it really did turn into a brainstorming session, which was wonderful. Right now you've got, not just the one person in a traditional RCA that made the mistake that's going to kind of brainstorm with you. You've got, tons of people, and even the people that didn't make the mistake, that was great too, right? We'd say, I noticed you didn't make the mistake. Tell me more about that. Tell me more. What helped you in the room? What tools did you use? How do you help your friends not make this mistake? What can we do to make it safer for your friends and your colleagues? And so it really turned people into, little patient safety experts themselves. And I thought that part was the best, because they all kind of left with a real positive attitude versus I made this mistake.
Yeah. And I'll just, I'll just add my kind of general 2 cents about debriefing styles and which to choose. And, there's a plethora of options, and I think starting with something that you're most comfortable with and that you feel like you can adequately, um, use, I think is the most important thing, for something that's potentially high stakes, like a root cause analysis. Would you kind of agree with that?
Yeah, for sure.
Okay. Well, that was the last. Oh, another one just popped up. Do you have training in qualitative methods, or did you use a qualitative methodologist for analysis of the debriefing?
Yeah, so I do not. And when we were initially starting this study, I became very good friends with a qualitative methodologist, and she's helped us all the way along. So that's been extremely valuable for me.
Great. So with that, I would like to thank everybody who joined the webinar. Shortly, you'll receive an email from IPSS that includes a link to an evaluation. Please take a few minutes to access it and provide feedback on today's session. Additionally, the recording of the webinar today along with the handouts, will be posted to the IPSS website in the near future. We hope you enjoyed the webinar today. We are working on scheduling more in the upcoming months. Be on the lookout for notifications to members. And for those of you that are not members, as I mentioned in the beginning, please consider joining our really amazing group. Not only are we a great organization, but our annual meeting, I think, is one of my favorite meetings that I go to. And this year it's in Toronto at the end of May. So please consider looking into that and joining us in Toronto. So with that, thank you very much, and I hope everyone has a good day.